You take it every morning without thinking twice. You've been doing it for months, maybe years. The pill is small, the routine is automatic, and somewhere along the way you stopped asking questions about what it's actually doing inside your body. But here's what I've noticed after years of working with patients on blood pressure medications. The people who understand their medication stay safer. And the people who take it on autopilot are the ones who get caught off guard. Today we're going to fix that, specifically for 3 of the most commonly prescribed blood pressure medications in the world: Amlodipine, Losartan, and Lisinopril. My name is Dr. James Anderson, and everything I share here is built around one goal: giving you the kind of clear, practical, honest information that too often gets left out of a 10-minute appointment. By the time this video ends, you're going to understand these 3 medications in a way that makes you genuinely safer, more confident, and far less likely to miss a warning sign your body is trying to send you. Before we get into the details, I want to tell you about Walter because his story sets up everything we need to cover today. Walter was 74 years old, a former engineer, precise and methodical by nature. He took his medications exactly as prescribed, never missed a dose. When his doctor added Amlodipine to his regimen, Walter figured it was just another blood pressure pill, one more entry in the pill organizer his daughter had labeled Monday through Sunday. Same category, different name, no big deal. That assumption cost him nearly a year of quality life. 3 months after starting the medication, Walter's feet had swollen so badly he couldn't fit into any of his regular shoes. His legs felt heavy and full by mid-afternoon. He started cutting back on how much he walked because movement seemed to make it worse. He told his son he was worried his circulation was failing. He was quietly terrified, spending his evenings searching for heart failure symptoms online. The real explanation was something far simpler and entirely manageable. But Walter didn't know that because nobody had ever explained to him that Amlodipine, Losartan, and Lisinopril are not the same kind of drug. They all lower blood pressure. That's where the similarity ends. Amlodipine is a calcium channel blocker. It works by relaxing the smooth muscle inside your artery walls so blood moves through with less resistance. Lisinopril is an ACE inhibitor. It blocks a specific enzyme your body uses to tighten blood vessels, and by blocking it, pressure comes down. Losartan is an ARB, an angiotensin receptor blocker. It targets a similar pathway but through a slightly different mechanism, and that difference matters more than most people realize. 3 different drug classes, 3 different mechanisms, 3 distinct side effect profiles, and 3 different sets of warning signs to know. When you understand that distinction, you stop interpreting your body's signals through a one-size-fits-all lens. Walter's swelling wasn't heart failure, it was Amlodipine doing exactly what Amlodipine does in a significant percentage of people who take it. Once that was identified and properly addressed, he was back in his walking shoes within weeks. The name on your bottle is not just a label, it's a category, and the category tells you the pattern. Let's go deeper on that swelling because it is one of the most widely misunderstood side effects in all of blood pressure medicine. Here is what actually happens inside your body. When Amlodipine relaxes the small arteries in your legs, blood flows in more freely. But the veins, which are responsible for carrying blood back up toward the heart, don't relax in the same way. You get an imbalance, more fluid coming in than going out. Pressure builds up in the tiny vessels near your ankles and feet, and that pressure eventually pushes fluid into the surrounding tissue. The result is what Walter experienced: puffy ankles, socks that leave deep indentations, shoes that stop fitting, legs that feel progressively heavier through the afternoon. This is not fluid retention from eating too much salt. This is not your kidneys failing. This is not heart failure beginning. In most cases, it is a predictable physiological response to how this particular drug works. Now here's where things become genuinely dangerous, and it's not the swelling itself that creates the danger. It's how people respond to it. Some people see the swelling, quietly decide to stop the medication on their own without telling anyone, and their blood pressure climbs back up while they feel like they've made a sensible, independent decision. Others keep taking the medication but begin restricting fluids because they believe they're retaining water, which is the wrong direction entirely and creates its own serious risks. And others, like Walter, simply endure it in silence for months, steadily reducing their activity, assuming something catastrophic is developing, and losing quality of life that they didn't need to lose. The right response is this: leg swelling on Amlodipine is a conversation your doctor needs to have with you. Not because the medication is necessarily wrong for you, but because there are adjustments, alternatives, and management strategies available. Elevating the legs, adjusting the timing of doses, or reconsidering which medication best fits your particular physiology are all real options. None of them happen if you suffer in silence. Now let's talk about Lisinopril, and specifically the most recognizable side effect in the entire ACE inhibitor family, the cough. Not a wet cough, not the kind that brings anything up, but a dry, persistent, scratchy tickle in the back of your throat that tends to worsen at night and doesn't respond to anything you'd reach for in your medicine cabinet. What makes this one particularly tricky is that it often doesn't appear immediately. Some people develop it within the first week. Others don't notice it until 3 or 4 months into treatment, and by that point, the connection to lisinopril never crosses their mind. They've been taking the medication for months without incident, so they blame pollen, dust, a lingering cold, or acid reflux. I want to tell you about Evelyn. She was 71 years old, an enthusiastic gardener, and when her cough started in late spring, she assumed it was simply pollen season doing what pollen season does. She bought an air purifier, she tried antihistamines, she mentioned it to her primary care doctor, who ordered a chest x-ray that came back completely clear. 6 months went by, the cough never left. Her sleep was disrupted almost every night. She was exhausted and increasingly convinced that something serious was being missed. When she came to see me, one of my first questions was straightforward. When did you start lisinopril relative to when the cough first appeared? She went quiet, pulled out her phone, and began tracing back through dates. She had started lisinopril 11 months before our visit. The cough had appeared roughly 4 months in. She had never once connected the two. When we worked with her primary physician to switch her to Losartan, which targets a similar blood pressure mechanism, but through a pathway that doesn't produce this type of cough, the tickle in her throat was gone within 2 weeks. 11 months of disrupted sleep resolved in 2 weeks once someone connected the dots. Now I need to draw a very clear and important line here, because there is a symptom in the lisinopril category that is not a nuisance. It is a medical emergency. If you are taking lisinopril and you develop swelling of your lips, tongue, face, or throat, especially if breathing or swallowing becomes difficult in any way, you do not wait until morning. You do not try a Benadryl and see what happens. You call emergency services immediately. This is a condition called angioedema. It is rare, but it is real, and it can compromise your airway faster than people expect. A dry cough is an inconvenience worth discussing at your next appointment. Throat swelling is a 911 call. The distance between those two things is significant, and I need you to have it clearly in your mind. Now let's move to Losartan, and a risk that I find particularly striking because it doesn't come from doing something careless. It comes from people doing what they genuinely believe is the healthy thing to do. Losartan, like lisinopril, works on the body's blood pressure regulation system. One of the effects of this drug class is that it can raise potassium levels in the blood. For most people, this remains within a safe range when appropriately monitored, but add certain common lifestyle choices on top of it, and the picture changes in ways that most people never anticipate. Potassium doesn't only come from bananas or supplements. It's hiding in something that's actively marketed as the smarter, heart-healthy choice: salt substitutes. Many popular low-sodium alternatives replace sodium with potassium chloride. A person who has been told to cut back on salt buys one of these products, uses it generously on meals every day, and is now steadily adding potassium into a system that a prescription medication is already pushing upward. The combination can raise potassium high enough to affect the electrical function of the heart. And what makes this particularly difficult to catch is that elevated potassium doesn't always announce itself loudly. It can appear as unusual muscle weakness, persistent fatigue, cramping in the legs, tingling in the hands, or a fluttering, irregular heartbeat. Sometimes there are almost no symptoms at all, right up until there are serious ones. Think about someone in your life, perhaps yourself, who has switched to a salt substitute in the last year or two. If that person is on Losartan or lisinopril, this is a conversation that needs to happen with a doctor. Not because the medication is inherently dangerous, and not because potassium-rich foods are something to avoid, but because the combination without awareness and appropriate monitoring can build into a problem that never needed to happen. Electrolyte powders, certain meal replacement products, and some over-the-counter sports recovery drinks also carry meaningful potassium content. They're not prescription products. Nobody thinks to mention them at appointments, and that's precisely why they matter. There's one scenario that doesn't get nearly enough attention in conversations about these medications, and it directly affects older adults more than any other group. What happens to these drugs when you get sick? Not seriously ill, not hospitalized, just a bad stomach virus, a few days of vomiting and diarrhea, or a hot week in summer with heavy sweating and inadequate fluid intake. When you're dehydrated for any reason, the same dose of Losartan or Lisinopril that was carefully calibrated for a well-hydrated body can behave very differently. Blood pressure can drop too low. Your kidneys, already working harder because of fluid loss, become more vulnerable to strain. Dizziness, weakness, faintness, and acute kidney stress can develop faster than most people expect. The medication didn't change, your body's internal environment did, and the drug is now operating in conditions it wasn't designed for. This is one of the most practically important things I can tell you in this entire video. Illness changes the rules, and if you don't have a plan for what to do when illness hits, whether to hold a dose, when to call the office, which symptoms should send you in for evaluation, you have a real gap in your safety. That plan needs to come from your prescribing doctor before you ever need it. If you don't have one, ask at your very next appointment. What should I do with my blood pressure medication if I get a stomach bug or can't keep food and fluids down? It is one of the most important questions you can ask, and it is one of the least commonly asked. Here's another scenario worth thinking through carefully. You have a difficult week. Your arthritis flares up, your knees ache, your back is stiff, and you head to the pharmacy for ibuprofen, something you've used for years without a second thought. But you're also taking Lisinopril or Losartan, and perhaps a diuretic as well. This combination, used regularly, can meaningfully reduce blood flow to the kidneys. In the presence of even mild dehydration, the risk of kidney injury rises substantially. This is not a rare, theoretical situation. It is one of the most common and most preventable patterns. The reason it slips through consistently is that patients don't mentally categorize ibuprofen or naproxen the same way they categorize prescriptions. It came from the shelf, not a pharmacy window, but your kidneys do not make that distinction. They respond to chemistry, not packaging. If you routinely use over-the-counter anti-inflammatory medications for joint pain, back pain, or arthritis, and you are taking any of these 3 blood pressure drugs, please bring that up with your doctor. There are often safer alternatives: acetaminophen, topical treatments, physical therapy approaches. You don't have to simply accept the pain, and you don't have to silently accept the risk. There is usually a better path available. You just need someone to help you find it. I want to spend a moment on something that sounds minor and isn't: dizziness. That brief, unsteady feeling when you stand up from the couch or swing your legs out of bed in the morning. The world shifts for a second, you grab the nearest solid surface, and then it passes. You tell yourself you just got up too fast and move on with your day. For many older adults on blood pressure medications, this happens regularly, and it's almost universally underreported because it feels too small to bother mentioning. Here's what I need you to hear. In older adults, a few seconds of dizziness is sufficient to cause a fall. A fall is sufficient to cause a fracture, and a hip fracture can redirect an older person's health trajectory in ways that take years to recover from, if full recovery happens at all. This is not alarmism. It is biology and physics working together in a way that deserves genuine respect. The dizziness occurs because your medication is doing its job, lowering blood pressure, and when you rise quickly, your cardiovascular system hasn't had time to compensate. Blood pressure drops briefly, blood flow to the brain momentarily decreases, and you feel it as that tilting, lightheaded sensation. The practical fix is often simple. Rise slowly, sit on the edge of the bed for a moment before standing, hold on to something stable, give your body a few extra seconds to adjust. But dizziness that happens consistently, dizziness that doesn't settle in after the first few weeks on a medication, or any episode of near fainting deserves a real clinical conversation. The dose may need adjustment. The overall combination of medications may need review. Treating this as too insignificant to mention is not a small risk. Let me address one more thing that creates unnecessary anxiety and occasionally leads to genuinely dangerous decisions: home blood pressure monitoring. Blood pressure is not a fixed number. It moves constantly throughout every hour of every day in response to dozens of variables: how well you slept, whether you had caffeine, whether you're in pain, whether you're anxious about the reading itself, whether you just walked in from outside. A single high reading on a random morning after a poor night's sleep does not mean your medication is failing. A single low reading after a day of inadequate hydration does not mean your dose is too strong. What matters is the pattern over time, measured consistently, same arm, same time of day, after 5 minutes of quiet rest. When people monitor inconsistently and react emotionally to individual readings, The decisions that follow are rarely good ones. Extra doses taken out of fear, skipped doses because one reading looked fine, anxious calls to the office about a number that in proper context was entirely unremarkable. Monitor with a method. Track across time. Bring the log to your appointment. Let patterns guide the conversation, not individual moments of panic. That one shift in approach reduces anxiety, improves decisions, and gives your physician far more useful information than a single alarming screenshot from a home device. These 3 medications work through steady, consistent presence in your system. They are not rescue medications. They are not meant to be taken reactively, increased when you're worried, or skipped when you feel well. Amlodipine, Losartan, and Lisinopril are doing quiet, essential work every day, and they do that work best when you understand them well enough to be a genuine partner in your own care. Know the side effects that are manageable, know the symptoms that demand immediate attention, know how illness and certain foods and over-the-counter products interact with what's in your prescription bottle, and know what questions to bring to your next appointment. That knowledge doesn't replace your doctor. It makes every conversation with your doctor more productive, more specific, and more likely to result in care that truly fits your life. If this gave you a clearer picture of what's in your medicine cabinet, share it with someone who takes these medications. And leave a comment below telling me which of these 3 you're currently taking. I read through them, and your experience might be exactly what helps someone else ask the right question before they need to.